everything, and I'll just turn things over to you now. Thank you.
Okay, thank you. Okay, so this patient encounter was done with Dr. Bailey down at the Gary office in Southern West Virginia. And the visit date was in December of 2020, so just about a month ago. So it was a 30-year-old male who was white, was seen in the office. He was first diagnosed with HCV about 5 years ago when he was 25 in Ohio, and he never had any treatment for HCV. At the time of the visit, he denied any alcohol or illegal drug use, including marijuana, but he does use tobacco products daily. And he was being treated for a mood/bipolar disorder at Southern Highlands in Welch. He was a previous IV drug user, but he hasn't used in the past year, which is what he said in December of 2020. And he does not currently drink alcohol. His last drink was in January of 2017. But like I said, he does currently smoke cigarettes. You can scroll down just a little bit, please. His comorbidities are bipolar disorder, mania, tobacco use, and HCV diagnosed in 2015. His current medications are listed there, just those 4 medications: the Depakote, benzotropine, hydroxyzine, and haloperidol. Based on his labs, he is not immune to hepatitis A, but he is immune to hepatitis B with the antibodies. He's 70 inches high, 197 pounds, so his BMI is 28.3. His labs, we got a whole bunch. Let's see, I won't read them all to you, so you can just scroll down a little bit more. Down at the bottom, so his APRI was 1.951. His child Turcotte Pugh was 5 and MELD score of 7. Let's see, so the really interesting thing about his labs were his HCV viral load. If you just want to scroll down just a little bit. Thank you. So down at the bottom here, the very last viral load of September of 2019 was 810, and then a month later in October there was none detected, and then February of 2020 it was 146,000, and then 8 months later was 2,050, and then 2 months later was 2,006,300. Or 6,300. So he's HCV genotype 3, HIV negative. So yeah, the interesting thing was his kind of fluctuations with the HIV or HCV viral load. And so the patient has sworn that during that time that he hasn't used any, or he wouldn't have any other reason for re-exposure. So yeah.
Thank you so much, Kate. That was a great case presentation. We really appreciate it. Before we jump into any of the recommendations, did any of the participants have any clarifying questions or comments or anything for Kate? Feel free to unmute or chat in. All right, and any hub members have some recommendations or comments as well?
Sure, lots of stuff to say. Interesting case. This is John, by the way, at the hub, one of the infection docs. So a couple things. I just want to go back to the case, and Mitra, can you pull up the transaminases, the AST and the ALT and platelet count? It kind of went by quickly and I didn't get a chance to really eyeball them too well. So AST, ALT, and then if you don't mind going up a little bit to the platelet count too. Okay, so 205. So the first thing I wanted to talk about is that in this situation, I don't believe the APRI. So remember, the cutoffs for the APRI would suggest that greater than 0.7 would be predictive of at least some fibrosis. Greater than 1 would suggest possibly even cirrhotic changes. The higher you go, the more likelihood that is to be right. But remember, the APRI is really only has 2 variables: the platelet count and the AST. And in this situation, it seems to be hijacked by an excessively high AST. And if you look at some of the alternative mechanisms to calculate fibrosis scores, such as his serum biomarkers here, which takes a much broader look at a broad range of biosynthetic and biodegradatory functions that the liver is supposed to be doing, it looks like it has a very optimistic, probably F0. We don't have elastography as a tiebreaker, but we do have a patient's age, and his likelihood of exposure was in the past 5 years, if we believe him. And it would be pretty darn hard to become cirrhotic in that time period. He does have genotype 3, which is again gonna accelerate the potential for rate of fibrosis compared to the other genotypes, but not that much. Okay, so in natural history, studies would predict that maybe 15 to 25 years to run into cirrhosis versus 20 to 30 for the other genotypes. And that's that variability really depends upon host factors and other illnesses or medications or confounders that the patient might have in their history. So just looking at him, you know, one of our previous hepatologists used to say it's pretty darn hard to have cirrhosis when you have a platelet count above 100,000. And I just don't buy it. He doesn't have the time period involved. So it's just, remember, APRIs will fail you gloriously if you have an aberrantly high AST or LT, or AST. And even the serum biomarkers can be wrong in the setting of an acute viral hepatitis when your transaminases are sky high, or you might have elevated bilirubin or something like that. So it's a challenge, and it's a fun case to remember that it's important to look at the whole clinical picture as opposed to over-reliance on a single value. I don't think this guy probably has a ton of fibrosis. Getting to your question about viral load, man, this is a really hard one to make heads or tails of. Big picture, and you just want to discuss when I pay attention to viral loads in hepatitis C. And remember, this is as opposed to a couple other viruses. Hepatitis B, the viral load matters a lot. HIV, the viral load matters, it's paramount to disease progression. But for hepatitis C, the quantitative value is less valuable, okay? And so it's not something I pay terrible attention to outside of trends. And this guy, I can't make any trend out of it. So I'll pay attention to viral loads if I'm choosing Harvoni as a therapeutic, which clearly you can't in this guy because he's genotype 3, but I'll pay attention to it if I'm trying to use short course Harvoni, because you have to have a less than 6 million. So that's one time I look at viral load, number one. Number two, as an answer to a yes/no question, after an antibody test, is there viral load present? And if the answer is yes, I'll want to make sure it's persistent for 6 months, at which point you call a patient chronic hepatitis C. And then the third time I look at it is in response to treatments. So you'd want to see an improvement to becoming undetectable while on treatment. And then probably the last time, or the fourth way I look at viral loads is if I'm trying to see if a patient's going to clear infection on their own. At which point you'd expect a steady decrement in viral load until it goes to undetectable and then stays there for 6 months. In a case like this guy, I would say it's positive, and that's about all I do with it. It's not necessarily, remember, higher does not necessarily correlate with a higher likelihood of developing fibrosis or anything like that. So it's unlike Hep B and unlike HIV from that perspective. So anyway, that's kind of viral load 101. It's there. It doesn't seem to be going away. And he probably deserves to be treated if you think he's in a good spot to be treated. Rachel Mitchell's on, and I'm going to need some help with Depakote. Remember, the anti-epileptics, whether they're used for anti-epileptic purposes or mood stabilization, do interact with basically all of our all of our direct-acting antivirals. And I don't have Depakote memorized. You know, you're limited on treatments for this guy because he's genotype 3, non-cirrhotic, treatment naive, genotype 3. You'd be looking at Mavorite for 8 weeks versus Epclusa for 12 weeks. Rachel, are you on? Can you help me out with the Depakote thing?
Yeah, so with the Depakote and your two options, because the patient also does have, it looks like the patient has West Virginia Medicaid, so Epclusa and Mavorite are both on their preferred list. So those would be your two options, and thankfully the Depakote from a metabolism standpoint is okay. I don't expect any significant interactions raising or lowering the levels of any of those.
Thanks, Rachel. Yeah. So I hope that answered the questions from the presenter. Great case, because you asked good questions. It's a really good question, and hopefully that made some sense.
Yeah, that was great. You answered the questions, and now I think we have a treatment plan to move forward. So thank you.
Sure. Yeah, I would love an elastography on him. Not right now, but you know. And by the way, maybe looking back and seeing if you had various transaminases to calculate an API range. So, you know, the natural history of liver enzyme elevation in hepatitis C is all over the place. You know, it can be some days normal and some days quite elevated. I'm sure there's a rhyme or reason for it, but I don't know what it is. You know, it could be all sorts of different things. That's a horrible answer, but it's an honest answer. So, so basically, you can find some days where a patient might have normal liver enzymes, and therefore their APRI would probably be a lot more optimistic. It does matter a little bit clarifying that long term. If we remember after treatment, this guy will probably have treatment success and be cured, have an SVR12, and go on his merry way, hopefully, after being adherent with Mavorite or Epclusa. And it is important to know how much fibrosis he has, because if he does have significant fibrosis, F3 or greater, he would require long-term, every 6-month HCC screening with an ultrasound, a right quadrant ultrasound. So, you know, sort of repeating these non-invasive biomarkers a couple times, you know, maybe repeating another, or if you have access to an elastography, I'm not sure if you can get that or not, but elastography would be a nice tiebreaker. And then, you know, calculating a couple different APRIs, maybe looking at the FIB4, which is another easy calculation to do that has a couple more variables and stuff like that, just so you can really see if it seems like he has a lot of fibrosis. Ultimately, if there is actually concern, you know, you'd need long-term HCC screening. So.
Great, thank you so much. Were there any other questions about the case from anyone from the group?
Hey, this is Kaylee. I jumped on a little bit late. I apologize, but I think I got the gist. And I thank you, Kate, so much for presenting a case today. I just want to point out too, I'm totally in line with Dr. Gilfus said. I think he touched on every single point I would have brought up as well. You know, with the APRI and FIB4 and all these non-invasive measurements at trying to estimate fibrosis, they're so much better at ruling out than ruling in. So like an APRI, I mean, it's really, you know, less than 70% sensitive and specific. And so we don't really, you know, if it's a low number, we can be more inclined to believe it than if it's a high number. And just as he said, you know, having any sort of elevation with AST, ALT, if there's high inflammatory activity, it's really going to be less reliable. I think the serum fibrosis marker, the FibroTest or FibroSure, I'm not sure which one you had, but that correlated with an F0. And so that's actually very specific at ruling out advanced liver disease. If it was kind of higher, you know, an F2 or F3, then I would be kind of more inclined to feel like the APRI was a more reliable test, because now you've got two values that are congruent. So I think, you know, you could even treat this guy without getting an elastography, and or even maybe just doing an ultrasound. To be honest, unless has a long exposure history, like he'd been injecting since he was 15 or something, and may have potentially had this for a long time, or if he was drinking really heavily. I know it looks like on the report that he stopped drinking in 2017, but you know, I would opt to treat him. If his liver enzymes stay elevated, you may want to get an ultrasound on him, but I would believe the fibro test, unless he's had either additional risk factors for liver disease progression, or his liver enzymes stay elevated after his Hep C treatment. But, you know, or if you choose not to treat him right now, if you think, you know, you want to wait a little bit longer due to compliance, or he's not really in care continuously with you and you kind of wanted to monitor him, I would make sure to get an ultrasound from that standpoint. But I wouldn't let that delay your treatment plan for him, I guess is what I'm trying to say. Does that make sense?
Yeah, that makes sense.
Okay.
Thank you.
Because I think that whenever we try to look at these non-invasive measurements, a lot of times you're going to see discrepancies, but just kind of remembering that they're really better at ruling out than ruling in. And so they're not as good at, you know, you shouldn't believe them as much if they're high. Just as Dr. Gilfie said, if you've got a lot of inflammation going on, so if the AST and ALT are elevated, it's not as believable as if, you know, those were normal and it would rule it out. But I think the fact that his fibro test was F0 is pretty reassuring. He doesn't have any underlying damage, since that's more specific at ruling out.
Yeah, that's what Dr. Bailey was thinking originally too, that we didn't really need another ultrasound or fibro score.
Awesome. Thank you all so much. And Kate, were there any other questions or anything else you wanted to share about the case before we move to the didactic portion?
I don't think so. I think we covered everything. Thank you all.
Perfect. Thank you so much. That was a really great case presentation. We really appreciate it. All right, Dr. Gilfus, I'll turn things to you. I gave you the ability to share your screen, but I also have it on my end if you prefer.
Are you saying you don't trust me to be technological?
Oh, I trust you. I trust you on your end with sharing the screen and everything.
We'll see what happens here.
That's good. Okay.
All right. Okay, so those that can see their faces up with a head nod, you all hear me okay and can see everything? Okay, good. So what I'm going to do is talk about HCV, HIV co-infection, definitely pertinent for the ID fellows here, hopefully pertinent to some on the audience as well. And anyway, open to questions. As always, please interrupt, chat in, whatever you need, and thanks for your attention. So I'm going to start off with a case that was interesting to me. This was a 45-year-old fellow with HIV, and his risk factor for HIV was MSM, so he never had any history of drug use. And when he'd entered care in 2008, we did our obligatory screening like we do on everybody, and his hepatitis C antibody test was negative. And we followed the patient for many years, incredibly compliant, wonderful guy, takes great care of himself. And, you know, about every 6 months or so, we do routine blood work on all of our patients. And I just put this one as an example in April. We tend to follow transaminases as part of a routine metabolic evaluation to make sure that our antiretrovirals aren't causing problems for the patient. And thank goodness things were looking great. So going along in April, things are great. Follow up around in his December 2013 labs, and what the heck's happening here? We have elevated transaminases all of a sudden. And you know, my typical response to any labs that I don't like is to not believe them. I'm like, no, that's not true. And so I just repeated them. 2 weeks later, I'm like, let's see what's going on. So repeat them, and lo and behold, they're still high. And so at that point, we have to work them up. So they're real. This was not a lab anomaly. And if you look down below at that time, we ran a hepatitis C antibody test, which was then reactive, which was then confirmed with viremia. So saying that he has active present virus. And yeah, that's not good. And talked to him, and you know, he had a new monogamous partner, sexual partner, and this partner did have hepatitis C untreated. So then we're like, aha, okay, this represents a really cool example for this particular didactic about hepatitis C with absolute evidence of sexual transmission. Okay, so there's no injection drug use. That's the only way he could have caught it. They didn't share toothbrushes. They didn't share anything else, razors, you name it. But obviously they were intimate. They were partners. And then as we follow the patient along, interesting things happen. His transaminases improved, and lo and behold, his viral load cleared. So actually I called him in celebration. I'm like, yay, life is good. Merry Christmas. You got a present for the holidays, and that was that your body took care of the hepatitis C virus on its own. And, you know, just being compulsive and like to prove that that's true, you know, 6 months later, the transaminase is still great, but my goodness, what on earth happened? His viral load came back positive again, and then never went away again. So I include this for a second reason, to sort of demonstrate that you don't ever tell somebody good news based upon one test result. You know, you want to make sure that the patient has cleared, not once, but cleared twice over several months before you confidently tell them that it's gone. So it's a very interesting case from that perspective. We don't have a lot of times that happens. The other potential explanation for this, by the way, was re-exposure. He remained with his partner who had hepatitis C untreated, and could have potentially, even after clearing this infection, been re-exposed and reinfected. I can't prove that. Really don't have an ability to prove that at all. But anyway, over time, his transaminases did what transaminases do with hepatitis C, and that's have good days and bad days. His viral load stayed high until, you can see the dates involved. This was 2013. This was interferon time. We didn't forget that. We're not going to do that to him. So we waited, and you know, around 2015 to 16, direct-acting antivirals became in vogue. We treated him, and he's cured. Yay! But a very interesting case, and you know, demonstrates the various, you know, Hep C throws 1,000 curveballs at you, and it's just maintaining an open mind with regard to, you know, thinking about each case individually. As I'm sure Kaylee Berner can tell you, there's 10,000 variations of hepatitis C, always keeping us on our toes. So basically, some themes for HCV, HIV co-infection. Number one, it's fairly common. There's a couple interesting changes in the transmission dynamics with hepatitis C, and that's you know, increased transmission in the setting of sexual transmission. So it actually becomes a genuine sexually transmitted infection in the setting of HIV. Increased perinatal transmission, accelerated rates of liver damage, and I guess good news in the end is that you know, response rates nowadays are as good to direct-acting antivirals for co-infected patients, that's those with HCV and HIV, as those who were mono-infected with HCV alone. But that's not to say it's easy. And so the ID fellows, I really want you to pay attention to the part where I talk about the drug interactions, because that's the hard part still. So again, I'm a clinician, not an epidemiologist, so I have to trust sites like up to date, et cetera, to tell me accurate information. And I can tell you in my own clinic, it's not terribly common. I'd say about 10% of my patients have HIV, who have HIV also have hepatitis C. Nationally, it looks like those statistics tend to be a little bit higher, maybe up to 30%. And it really probably varies depending upon the particular cohort, the particular country, the particular time frame you're looking at to really get an accurate idea of what the rate of co-infection is. Really the risk factor, if the risk factor is injection drug use, your rate of co-infection is going to be much, much, much higher, as opposed to if your risk factor is something like heterosexual sex. And that evidences itself not only here in the United States, but even internationally. If you look in some countries where the primary risk factor for HIV is drug use, such as in Russia and Eastern Europe, there's a very, very high co-infection rates. Interesting. So it tends to follow. This is a cool statement and totally makes sense if we think about it. It says the sequence of infection is often based on the risk factors. So if you have someone who has injection drug use as their primary risk behavior, you tend to run into HCV before HIV. Not a rule, obviously. We've seen the opposite, but just this is playing the odds. You know, HCV much more common than HIV. And then the opposite is true in the setting of sexual transmission, where you basically have to have HIV first before HCV becomes sexually transmissible. And this isn't a true, across the board, but we know that transmission, and actually I'll go right onto this slide because it tells you the transmission of hepatitis C via heterosexual sex is very challenging. It doesn't happen frequently. And men who have sex with men who are HIV negative, it is also transmission of HCV is uncommon. But it's really in the setting of co-infection where you have someone who has an HIV infection, HIV positive, HCV becomes more frequently sexually transmitted. And that can be true for either partner, whether they be insertive or receptive partner, because it looks like seminal fluid increases, or I should say the viral load of HCV increases in seminal fluid. Also, HCV becomes evident in rectal swab samples. So the why is there. It's just interesting. So just recollect that MSM in and of itself, not a risk. MSM in the setting of HIV allows HCV to become a genuine STI. Wow, that was a lot of abbreviations. I basically just did the alphabet there. I apologize, but it made sense. Perinatal transmission. Okay, so another thing that changes. Obviously, we always quote this 5 to 6% rate that's unmodifiable from mother to child transmission for hepatitis C. Doesn't seem to matter what we do. That's what the rate is, somewhere in that zone. And that's a debated number, exactly what it is. But I think as a concept, when you put HIV in the differential, what is known is that you have an increased rate of mother-to-child transmission. And in general, it might be about double. So maybe 10% as opposed to 5, somewhere in that zone. Again, take the numbers with a grain of salt, what they are, just understand the concept. And again, the why, similarly to why HCV becomes an STI in the setting of HIV, you have potentially in the setting of mother-to-child transmission, you can have HCV detectable in cervicovaginal fluid in HIV positive patients, but less so for HCV monoinfected patients. So this is just a slide, actually kind of fits in with Kate's presentation today about talking about viral loads, and I kind of went through the differential of about 4 different reasons you might look at HCV viral load. But just be aware, these are both fascinating viruses from a virologic standpoint. They're very different insofar as HIV being a retrovirus is going to archive itself via DNA into the host genome, whereas HCV is not going to and will therefore be more of a curable disease process. The viral loads in general for HIV, and this is all over the place, but if we talk about in general, HIV viral set points after an acute retroviral syndrome, after you get a very high viral load, it tends to settle down for most patients into the thousands, 20,000s, 30,000, sometimes higher, sometimes lower. And it really matters. That viral set point sort of can really help determine how long it takes a patient to progress to significant immunodeficiency, including AIDS. Whereas for HCV, that viral load tends to be usually in the millions. Again, that's a huge generalization. I've seen them anywhere from hundreds to tens of millions, but it doesn't matter as much. It generally really doesn't matter as much outside of the trends and the reasons I talked about earlier. So, and again, just trying to conceptualize the numbers involved. I actually can't conceptualize it, but just imagine you have that many progeny a day. Good thing viruses don't have to save to put their kids through college. That would be hard. But they have a lot of they replicate themselves a billion times a day, and they're very error-prone viruses, and that error-prone nature is very important for them because errors, when you don't really care about your progeny, may induce variation that can allow them to eventually become resistant to antivirals, can help them escape immune checkpoints, etc. So it's actually a survival advantage to play the lottery so many hundreds of millions of times a day if you're a virus. And basically, after a patient, if a patient with HCV, the viral load may go up in the presence of HIV, okay? And this might be related to immunosuppression. It might be direct viral interactions. In general, the interaction between HCV and HIV is kind of what you'd expect. This is a truism in terms of both of the virology and from clinical outcomes. It rewards pessimistic thought. So anything that you think might happen probably does, for the worse, okay, in the setting of HIV and hepatitis C. And you know, that's not always the case. Other chronic viral infections, which are common co-infections, such as hepatitis B, I know we've had entire didactics on that. The relationship between hepatitis C and hepatitis B is much more unpredictable. Whereas these two viruses tend to have an additive, negative, deleterious effect on each other. Hep B and Hep C are much more random, and there could be a competitive inhibition of one and the other, et cetera, et cetera. But in general, these two viruses help each other at the expense of the host, and you can see increased rates of fibrosis, and that might be because the patients have an immunosuppressant effect of their concomitant HIV. We certainly always consider that when we look at host factors, what makes one patient progress more rapidly towards fibrosis. Remember, we always look at things like age, alcohol, hepatic steatosis, but immunosuppression and immunosuppressant use is always listed on there, but you know, that can also be endogenous from your own co-infection with HIV. Remember, the word inflammation in hepatitis C is also a very bad word. It's that consequence of both viral activity and then healing and scar tissue formation, which allows a patient to eventually get cirrhosis. And in general, HIV is a very pro-inflammatory condition. The reasons for this are complex. I don't really want to get into. It does have something to do probably with a reduction in our gut mucosal associated lymphoid tissue and just an overall activation of inflammation, for a very generic term, systemically. And it's not good. It's not good for the host, and it's leads to increased fibrosis rates. And this is sort of everything. If you paid attention to what I said a second ago, I said this rewards pessimistic thought. So how do we think HIV would affect hepatitis C? Well, higher rates of morbidity, mortality. You're less likely to clear HCV infection. That was a typo, by the way, that should be HCV. If you remember the case I presented, this guy looked like he cleared his infection initially, and then it came back. If that in fact was the situation, he was very lucky. You know, the natural history of monoinfection for HCV, we really don't know how often people clear an acute hepatitis C. It's anywhere from 10 to 45%. It's this big range of potential for clearing. But for HIV, it tends to be right around that 10% likelihood of clearing, so even less. So it would have made him pretty unlikely, and he didn't, clearly it didn't work. And of course, more rapid rates of liver fibrosis, and it can be pretty close. By the way, this gentleman, if you see, I only followed him for 3 years. By every non-invasive marker I have, he's an F3, which is kind of mind-blowing. And you know, he didn't have a big alcohol history. He was a thin, fit guy. I don't really have another good explanation for it. His transaminases normalized after cure, so it does seem to all be hepatitis C. So I've always remembered his case because I had absolute documentation of less than 5 years of infection, yet a lot of fibrosis. Interesting. This is one that I threw on here this morning and added this on from the last time I presented. And that's in higher rates of extrahepatic manifestation. And this is definitely things I've seen clinically. I see a lot of cytopenias in patients who have HIV and HCV co-infection. And remember, the extrahepatic manifestations of Hep C are very broad, but giant categories. You think of autoimmune phenomenon, you think of malignancies such as lymphomas and the sort, and even increased cardiovascular disease, et cetera. And everything gets worse and more common in the setting of a co-infection. So as I mentioned, all of this stuff sort of is exactly what you'd predict, unfortunately. And even HCV, oh, wrong word, HCC, hepatocellular carcinoma, can occur more frequently, more aggressively, earlier, et cetera. So bad, bad, bad. Okay, so moving on from that, how about testing? Remember, in general, we very much trust our screening ELISA antibody, our serologic test. Remember, there is a window period for any serologic test to turn positive. So if you're testing somebody shortly after a risk behavior, you have to make sure you follow up down the road if you're relying purely upon antibody testing, maybe even following for 6 months before reliably telling them that whatever risk behavior they had did not lead to hepatitis C. But say you're seeing somebody who is a co-infection, can you still trust that antibody? And the answer is, in general, yes, as long as their immune system is intact. So if their CD4 cell count is 800 and they've been steadily on antiretrovirals and a good immune reconstituted system, you can trust their antibody response. However, if you are seeing them when their CD4 cell count's very low, and you still have an unexplained potential transaminitis, or potentially a person who has a strong history of risk behavior that could have put them at risk of HCV co-infection, you can go ahead and just look for the virus. Remember, doing a viral load assessment also very much shortens your window period. You know, there's studies that say, as opposed to having to wait many months to ensure no serologic conversion, the PCR testing can be positive very early on, within a week to 2 weeks. So it is a nice test to do. It's obviously expensive and not really condoned as a primary screening test. Hope that made sense. How about the effect of antiretrovirals? So as you'd expect, it's good. It probably helps. And more so, there's no reason that you wouldn't want to have a patient on antiretroviral therapy, period, for HIV. It's condoned to start ASAP on patients with HIV, as long as they're going to take their medicines and can get it. And it does what you'd expect it to do. It would decrease liver-related morbidity, decrease fibrosis progression, decrease everything that you'd hope it would do. So again, very rational and reasonable. You can sort of think through these, but do know that it's not enough. So unlike hepatitis B, where the antiretrovirals that we're using for HIV also tend to treat Hep B, that's not true for Hep C. So for Hep B, we're lucky. The tenofovir-based derivatives, whether they be traditional tenofovir or TAF, will happily treat hepatitis B, as will our limivudine and emtricitabine. We don't have any similar luck with hepatitis C, so we still have to dedicate direct-acting antivirals towards it. How about toxicity? I guess the only thing to really know here is that it can happen. It's not a reason to not give somebody antiretrovirals. Do be aware that, you know, IRIS, the immune reconstitution inflammatory syndrome that tends to happen when somebody has a really, really depleted CD4 cell count, And then if we give them our new potent antiretrovirals, especially the integrase strand inhibitors, we tend to see really, really robust recovery of the immune system. And you can see reaction to sort of previously unrecognized infections in that scenario. That's a concept known as IRIS. And really, there's not a pathogen I can think of that a patient can't develop IRIS towards, whether it be PML, Cryptococcus, tuberculosis, PCP, Kaposi's, you name it. There's an IRIS phenomenon described towards it. And HCV it can happen. So you can get a person who gets a liver enzyme flare after starting antiretrovirals, and what do you do with it? Nothing. You watch the patient, make sure they're not having genuine fulminant liver damage or anything, and in general, watch and see what happens. Potentially treat their Hep C. It's a nerve-wracking experience because, I think all of us clinicians are really go by the do no harm principle first. And when we start a medication that then induces harm, it's hard to do and makes us nervous. And a lot of times we want to withdraw that therapy. But with IRIS, a lot of times what you want to do is keep going within reason. Obviously not if the transaminases are thousands high. I'd probably back off for a bit or consider steroids, etc. Or as I wrote up there, close follow-up is prudent. How about treatment? So despite what Kaylee Berner would have you believe, while I have practiced in the last century, I wasn't involved in bloodletting or anything. That was before my time. I was, however, involved in interferon therapy, and it was something I was very comfortable with and confident with. But let me describe glorious failures to you. I did not have a single success at taking an HIV, HCV co-infected patient through treatment. Every single patient I tried, I had to stop. And the whys there were either subjective terrible fatigue or objective cytopenias. And a lot of that had to do with ribavirin interacting with a drug we used to use commonly, which is AZT. We don't really use it much anymore. But I literally had a 100% failure rate for the old interferon era stuff. And they quote you, in general, we used to tell patients, good news, we have if you don't have HIV, maybe a 50% success rate. And if you did have HIV, we used to say maybe a 15% success rate. And, I would hit on the low end of that, definitely. Now, since then, the direct acting antivirals, really the greatest news I can tell you is that if you're able to get your patient on therapy, their SVR rate, so their chance of cure, is the same as uninfected, that's mono-infected HCV patients. So co-infected HCV, HIV should have similar SVRs as HCV mono-infected patients. And the only alterations that we really have to consider doing is, remember Harvoni on occasion has an 8-week option if your viral load is less than 6 million and a couple other factors that you're not cirrhotic. Well, it's not an option if you're HIV co-infected. So all Harvoni should be 12 weeks. And remember, Mavorite has new packaging that says 8 weeks for all treatment naive patients, whether they be cirrhotic or non-cirrhotic. But that's not true for HIV co-infected patients. You'd want to, if your HIV co-infected patient does have compensated cirrhosis, you'd want to treat them for 12 weeks. And really the issue otherwise is drug interactions. And this is the part where you can glaze over if you're not an ID fellow. But if you're an ID fellow, this is where you need to pay attention. Actually, I should just have a picture of Rachel Mitchell up here and say, call Rachel Mitchell, because that's what I would do. So, and if you can't reach Rachel Mitchell, you can go to hcvguidelines.org, okay? Which is, again, a great thing. And then you go down to management of unique and key populations. And then right here, patients with HIV, HCV co-infection. And I go to this page every time before I treat a co-infected patient. By the way, I don't think I told you the good news. Every patient, maybe I did say it, I have a 100% cure rate now with the direct-acting antivirals in our HIV patients. So I've not had any treatment failures there now. Yay, much better than 0. So if you click on this HIV, HCV co-infection page, there's a couple of things that are important, but basically this is an important principle. You don't want to have treatment interruption, so you don't want to stop antiretroviral to permit the use of HCV direct-acting antivirals. Why would you ever contemplate that to begin with? Well, because of drug-drug interactions. It might look like an attractive concept to just put a patient's antiretrovirals on hold for a little bit. Don't do it. It's not worth it. There are other options. And so you can come up with a treatment option for most situations. This just basically is the verbal form of this chart. And this is, by the way, everything's on that page I just mentioned, the hcvguidelines.org. So in general, I want to look at this table. It's got the antiretrovirals categories on the left, and then the HCV therapies across the top. It's got Harvoni, Epclusa, Zepatier, and Mavorite, and Vosevi. So remember, just giant principles. Protease inhibitors shouldn't go with protease inhibitors. So remember, these are the 3 anti-hepatitis C drugs. That's Zepatier, Mavorite, and Vosevi are the HCV drugs that are protease inhibitors. So don't add those to the protease inhibitors for HIV, the ritonavir, etc. drugs, because they tend to interact with each other. Remember, the general take on protease inhibitors is that they led to enzyme inhibition and therefore toxicities. The NNRTIs, a little bit harder to predict. Remember, favorins for some drugs is an inducer, for other drugs is an inhibitor, so it's hard to predict. Same with etravirine. Remember, for the integrase inhibitor, the cobicistat acts like a protease inhibitor, and so you, as predicted, at least have a little bit of concern with a cobicistat containing regimen. But what I really want to do is go through, you know, the fellows are not in the room, but I'll pretend I see you nodding. What do we actually have our patients on from antiretroviral standpoint nowadays? We have them on bictegravir. Look at the good news here. Nothing to worry about, bictegravir. Or we have them on dolutegravir. Nothing to worry about, okay? And then what sort of backbones do we have them on? Well, you know, it's rilpivirine's becoming hot. Remember, there's a new injectable cabotegravir rilpivirine coming out. So anyway, rilpivirine is part of Juluca and a couple other combination products to allow people to be on fewer drugs. And rilpivirine as an NNRTI looks good. And then what backbones do we tend to use? In general, everybody's on either emtricitabine or lamivudine, so nothing to worry about. And then the old tenofovir formulation, which we're phasing out, does have some concerns with Harvoni and Epclusa for increasing tenofovir levels and therefore having some potential for causing kidney issues. But the good news is TAF, the tenofovir 2.0, does not tend to share those. So the average regimen, which I'd say 90+% of our HIV patients are on, either Tivicay and Descovy, that's emtricitabine and TAF plus dolutegravir, or bictegravir plus emtricitabine and TAF, or Epsicom, or Triumec. You know, you have dolutegravir plus abacavir, emtricitabine. The punchline is all these is most of the regimens we actually use for 90% of our patients don't have any issues, which is great. And that's really different, honestly, than 2015 when HCV guidelines first put this table out, when protease inhibitors were much more in vogue, when old-fashioned tenofovir was our primary backbone. We did have some concerns, but there you go. That's the table made happy, I think. Now, I already mentioned that HIV's effect on HCV sort of does everything you'd expect it to do if you're a pessimist. And the same thing with HCV's effect on HIV. So what do you think it might do? It might make everything worse. The answer is yes. It tends to make, and that's untreated. So it tends to make, you know, you more rapid progression towards immune compromise. So you're more likely to have an AIDS presenting opportunistic infection, or AIDS defining, I'm sorry, opportunistic infection, less likely to gain CD4 cell counts after antiretroviral therapy alone, more likely to have inflammatory and non-inflammatory complications from HIV, and just overall badness. And again, it's what you'd expect. And another reason to go forth and treat your co-infected patients if possible. So I open it up to questions, comments, anything that y'all might have. And most importantly, thank you for your attention.
Thank you, that was awesome. Any comments, questions, thoughts from the group? Dr. Gilfuss, I knew I could trust you with your screen sharing. That was great.
Oh, here, sorry, I should stop sharing. Or did
Oh,
you
no, you're good. It was stop sharing now. Thank you. Feel free to chat in, anyone, as well, and I can read it out for you. All right, well, if there are any questions after the fact, just feel free to email me and I'll make sure to send them to Dr. Gilfuss to have them addressed and everything. But big thank you to Kate for that awesome case presentation. We truly appreciate it. Really facilitated a lot of great discussion. And thank you, Dr. Gilfuss, for that great didactic as well. I'll be sure to attach your PowerPoint to the recap email so everyone should have it on hand after this. The only other announcement I have is our next session is on February 11th, and Christopher Hale is going to be discussing insurance coverage. So keep an eye out for that reminder, and we'll see you all next time. Thank you.